and welcome to the Patient-Centric Interest Group webinar for July 2024. My name is Neil Spooner. I'm the chair of the Patient-Centric Sampling Interest Group. Today, I'm really excited to welcome Makubu Kimani and Rose Mbati, both from the Kemri Wellcome Trust Research Programme. And they're going to talk to us today about acceptability and validity of microsampling for serosurveillance in Kenya. Rose, Makubu, welcome to this Patient-Centric Sampling Interest Group webinar. I'd like to hand over to Makubu first, but before we get there, just a few little slides, a little bit about the Patient-Centric Sampling Interest Group. These webinars are brought to you due to the support of our sponsors who are listed here on this slide. If anyone would like to be a sponsor of the Patient-Centric Sampling Interest Group, please connect to us through our website. The agenda for today, after my brief introduction, you'll hear from Makubu and Rose. Just a reminder that if you have questions, please use the chat function on this platform that we're using. A reminder that the event is being recorded, and we'll go through the Q&As at the end of the program. So with no further ado, I'd like to welcome Makubu, who's going to be our first speaker, and Rose will take over later. Thank you, and I'll pop back in later.
Thank you very much, Neil, and good evening, good afternoon, depending on what part of the world you're in. Welcome to this webinar. I will be speaking to you. Well, this will be a tag team, so I will take the first bit of it, where I'll just try and introduce you to what we set out to do, how we did it, and then Rose will walk you through our lab methods, and then if you're not too tired of me, I'll then come back and tie it all together at the end of this. So I suppose just to get started, I'll just I'm probably preaching to the choir, but really just to bring everyone up to speed. Why we set out to do this is because, microsampling, like everyone can imagine, is really great because you can actually scale it up to reach lots of people with minimal effort compared to, say, collecting venous blood draws from everyone. Related to that is it's almost anyone can do it. You don't have to have a medical background, you don't have to be a nurse. You can teach anyone to do a fingerprint, and so that again goes back to point number one, where you can scale it to lots of people because you don't need too much skill. The way microsampling techniques have been developed is that then you can move them very easily, you can store them very easily. They take very little space, they don't need too much urgent, say, processing and separation. So that also makes them very convenient. And finally, at least in the presentation we're going to make, it does make sense to do microsampling because you can then you can use your samples very rationally. So from one sample, you can carry out multiple pathogen analysis. So with that background, I'll then introduce to the study site and what we set out to do. So this is actually a very small bit of a much larger piece of work. So this little pilot study was nested within a much larger serosurveillance study that I would be glad to speak about later on if anyone's interested. It's a multi-site study. And so what we set out to do in this pilot is just to see what is the acceptability of microsampling techniques by both study participants and also by operators. How easy is it to then transport and handle these collected samples and store them in different storage conditions? And finally, what would be the sample integrity of those samples, what would be the integrity following different storage conditions and storage times compared to a gold standard that would be venous blood. And so Just to contextualize what the chemists, the Kenya multi-site integrated serosurveillance study was, like I said, it's a multi-site study. So this is a map of Kenya, which is on Eastern Africa. And so where we are is that at least Rose and I is right at the Kilifi, which is by the Indian Ocean. And then where there's a very long-running health and demographic surveillance system run by the Kemri Wellcome Trust program. And then in Nairobi, they have what they call the Nairobi Urban Health and Demographic Surveillance System. And then finally, in Western Kenya by Lake Victoria, there's there's a health and demographic surveillance system within the city of Kisumu. So the idea was that hopefully this gives a diverse coverage of different populations across Kenya. So how we designed this pilot is we decided to try and make it a comparative study. So we would have 3 arms. So the first arm would be, like I said, venous blood draw has always been the standard for serosurveillance, at least in our setting. And so that we made it the gold standard against which everything else would be compared. So we'll then do a finger prick where we'd collect capillary blood and directly transfer that to either Whatman's card or a Mitra device. The specific Whatman card we used is the Whatman 903, and this was based on previous work done by the Colorado University School of Public Health that showed that was probably the best filter paper. So before we began sample collection, we engaged in quite a rigorous training just to standardize everything across the 3 sites. So we had not I was leading this piece of work and had not worked with the Mitra device, had worked with filter papers before. And so we were fortunate to find experts who had worked with Mitra devices before. And so they provided standardized training for both the field teams and also the lab staff so that everyone across the 3 sites would be doing the exact same thing. We also held practical sessions. Actually, people did do this practicum on themselves. So one person would get pricked and the other one collects, and then they would change over just so that people have a feel of how easy it is to do it once they are actually doing it on site. And then, as is customary, we before everything began, we made sure that we have all our consumables on site. This was just a pilot, so the sample size was just a convenient sample. So the full during the rounds of serosurveillance, we've been targeting to get about 850 individuals at each HDSS, and so a convenient sample of about 10%, which is 85 participants, was selected just to see how well this pilot works. So the data, at least the field data, are about a year old. Data collection began last year in July and ran through to September at the 3 sites. Like I said, we created a standardized operating procedure, so everything was done exactly the same in terms of sample collection. Then Rose will talk about the protocols that she came up with around sample storage and time of elution. So what we wanted to do is, like I've said before, is just to assess for how acceptable would be this microsampling compared to the gold standard. How easy would it be for the healthcare providers that we've trained to use them, and how and also from the participants' point of view, how acceptable is it? And so we did this both objectively and subjectively. So objectively, we just looked how long did someone take time to do this, what is the sample integrity, how acceptable was it, were there refusal rates? And then the subjective ones are, like I said, it was a tag team. So one of the people in the team would just observe as they're collecting the sample, how much was the other person struggling to do everything? How much pain did the participant seem to be in at the time? Is there a lot of squirming and movement? Is there a lot of fear? At the lab level, which Rose will talk about, she assessed for IgG antibody levels against 7 vaccine-preventable diseases. And so the idea was to compare what are the antibody quantities from the two types of the dried blood spots, i.e. the filter paper and the Mitra, compared to what we think where we said the venous blood is the gold standard. And then we also wanted to assess what would be the impact of freezing the DBSs versus room temperature. How would that affect the stability of these antibody levels? So for that, the tool that we used, which was then moved into a soft system on a tablet, the dashboard asked very simple questions, just a couple of questions. One would be, do you agree, yes or no? And that would talk about refusal rates. Then we asked about how easy it was to fill up all the spots either on the filter paper or all the tips on the Mitra. And then the person, if they said they felt any challenges, they would give a narrative of what they thought were the challenges. And there would be a few narratives in my results. Then we asked them, in their opinion, which they thought was the easiest. And so again, this is very subjective, but this was based on, how much time it took for them to do, how many fingerprints they had to do to fill all the spots on the filter paper or the tips on the Mitra devices. So I'll give you just a very, it'll just be a taste of what the field epidemiology data is like. There will be much more data once we are doing the publication. So this is just to give a flavor of what the results were saying. So now there's two. In my opening remarks, I talked about 3 HDSS sites, but these data I'll present are restricted to just 2 of them. The third site, we don't yet, the data for that are not ready, so I'll restrict it just to 2. So hence the sample size, like I said, was a convenient sample. So in total, 173, about equally distributed between the 2 sites. Interestingly, for the Nairobi site, and this was a convenient sample, seemed to be more male-centric. About 2/3 of the respondents were male compared to the Kilifi site, where it's almost about equally divided. In terms of the age categories, probably the only interesting thing that I would call your attention to is that at the Kilifi site, the sort of elderly group of participants are quite a number. It's almost a third of them. So, those from 55 to about 65 years are about 30% of the respondents, or just slightly under that, compared to the Nairobi urban site, where it seems to be a very young sort of age strata. And again, that's not unexpected, being an urban setting. In terms of the user experience, so here we were just asking them what did they think was the easiest device to use. So interestingly, over a third of all the respondents, 36%, were equally, they were ambivalent. I could use any of them if they were made available to me. However, when you then titrate that a bit more, people who are used to doing the venipuncture felt them. So about 27% of respondents said, well, venipuncture is actually much easier than the others. And then Mitra being the newest, and the filter paper were almost equally, their ease of use was about the same. So then we asked them, why did they think one device was easier to use compared to the other? And interestingly, if you go back to venipuncture being the most preferred when you ask them to be specific, interestingly and useful to this webinar is that participants felt, the healthcare providers felt the venipuncture was the easiest to do because it caused the least pain to participants. So really interesting because it's a patient-centric webinar, and our respondents, totally unaware that this data would be presented in such a setting, prioritized the comfort of the participants over anything else. Then we asked them, did you at some point need to do more than one prick? And a good proportion, actually, the majority said yes, one prick was really necessary, and the reasons for it, by and large, again, these are titrated down towards those who responded, so it won't be 100%. But of those who gave a response, about 65% said the sample was insufficient, so they would prick a finger and then don't get enough droplets, and so have to prick another finger or another side. Clotting could have would have happened. So that's really just a flavor of what the field data are saying. We will have much more data as we get data from the third HDSS site, but for now, I'll leave it at that. And I'll then hand this over to Rose, who will walk you through the lab methods, and then we'll tie it together. So over to you, Rose.
Thank you so much, Makobu. And just to pick up from where Makobu has left off, so I'll majorly focus this talk on the lab aspect of this study, and that is the comparison of DBS samples, that's filter and Mitra versus plasma, for the serosurveillance of vaccine-preventable diseases. Yes, so for the lab analysis, we use the Luminex-based multiplex immunoassay, and this is by using the color-coded beads, which are dyed into spectrally distinct sets. So then each unique bead set can then be coupled to a specific antigen. This allows for assaying of multiple analytes simultaneously, and this is in a single sample volume in one run. And of course, this analysis is conducted on the Luminex platform, where each bead set then can be distinguished and the signal quantified for each of the analyte that is in the sample. So here at the program, that is Camry Wellcome Trust, we have two Luminex analyzers. That's the picture on the right. This is for we have Luminex 200 and MagPix platform. Yes, so for this study, we leveraged an optimized multiplex immunoassay in which we can simultaneously quantify IgG antibody responses against 7 vaccine-preventable diseases, and that's diphtheria, tetanus, pertussis, measles, mumps, rubella, and varicella. And this VPD assay is a well-validated assay using the international standards, and this was developed by the RIVM Institute, and this is in the Netherlands. So this assay was adapted here at the program and validated using a validation panel that was provided by the RIVM team. Just briefly on this 7 VPD immunoassay, as I mentioned, it's a quantitative assay. So we have standards, and that is the anti-rubella immunoglobulin international standard. So this standard functions as a multivalent reference. So it contains IgG antibodies against all the 7 analytes. So therefore, the standard has been calibrated for all the 7 targets. So these are sample standard curves for some of the targets, and that's diphtheria and tetanus. And as I mentioned, the antibody responses are quantified in international units per ml. So to assess the performance of this assay and just to ensure that it's working optimally, so we do have a validation panel, and this is just a set of samples with varying concentrations of antibodies against these 7 targets. So therefore, every time we couple beads to antigens, then we're able to assess for bead batch variations. And this is by comparing with previous bid batches. For example, the correlation on the right side, that's the top panel, that is that of the most recent coupling done sometime this year, and we've compared the data with that of RVM in 2018. And of course, when we run the samples, we do have the controls, and we perform analyte-specific QC trend analysis, where we get to plot the concentrations on these charts and assess if the concentrations are within the acceptable limits. So this is how we're able to accurately assess the performance of this assay. For this study, the analysis of the DBS filter and Mitra versus plasma, we did assess the IgG antibody responses at different storage conditions and the elution time points. And as Makobu mentioned, we collected around 173 samples, and that is paired plasma samples and DBS filter and Mitra. And these samples were almost equally distributed between the two sites. And for the Kilifi site, one DBS filter and Mitra was missing, but we assayed all these samples at baseline. So baseline, we refer to it as day 0, and meaning that these samples were eluted within 24 hours after sample reception at the lab. We also had another batch of these samples that were stored at room temperature, and then we eluted them at day 7 and another batch at day 30. So for the Nairobi urban site, these samples were stored at room temperature, and another batch was freeze stored at -20 degrees Celsius. Then we got to elute the samples after 90 days. So for this study, then we assessed the antibody responses at 3 different storage conditions, and that is at baseline. We have freeze storage at -20 degrees Celsius for 90 days, and there's room temperature storage, and this is at day 7 for 7 days, 30 days, and 90 days. So this VPD immunoassay was really optimized for utility of plasma samples. And these plasma samples are assayed in duplicate dilutions. That's 1 in 200 and 1 in 4,000. So therefore, to estimate the optimum volume of elution buffer. And the elution buffer that was used here is the assay buffer. So for the DBS filter samples, then a bunch of the DBS was eluted in assay buffer, and then we conducted a serial dilution. This is just to determine the optimum volume of elution buffer. This is at a point at which the antibody responses of the DBS samples had the strongest correlation with that of plasma samples. A similar case to for DBS Mitra, again basing it on the assumption that these Mitra microsamplers absorb a defined volume of blood, and assumption that the hematocrit level is at 50%, then we did determine the optimum volume of elution as well. And this the antibody responses then were compared with the corresponding plasma responses. Yeah, so just directly to the results, we did observe a strong correlation between antibody responses at in DBS samples. That's both DBS filter and Mitra. This is when compared with plasma at baseline, and baseline is the immediate elution of samples actually within 24 hours. So this correlation graphs here, this is of DBS antibody responses. This is on the y-axis against the antibody responses of plasma. And the vertical dotted lines represent the seropositivity cutoffs, and the diagonal dashed line is the ideal line, meaning at a perfect correlation of 1. So the red scatter points and the correlation lines represent DBS filter, and the blue DBS Mitra. As you can see, there was a high correlation the correlation coefficients are all above 0.9 for all the 7 analytes. And this demonstrating that really DBS samples, that's both DBS Mitra and filter, can be used for the detection of IgG antibody responses against diphtheria, tetanus, pertussis, measles, mumps, rubella, and varicella. So also, to assess the impact of freeze storage on the stability of these antibody responses, and this storage was at minus 20 degrees Celsius for 90 days. Again, comparing the antibody responses from both filter and Mitra with matched plasma samples, all the analytes seem to have demonstrate a strong correlation, all above 0.9. But if you can check clearly, there's a strong, despite the strong correlation, you can see there's a slight decline in the antibody levels. And this seems to be more evident on the filter paper. And as the red scatter points and the correlation line, there seems to be a slight deviation from the ideal line. And this is especially more on diphtheria, tetanus, pertussis, measles, and rubella. But even with this slight decline in the antibody responses or levels, the serostatus of these samples is largely maintained. And finally, assessing the impact of room temperature storage on the DBS samples, and of course, assessing the stability of these responses. So we did conduct point assessments at various durations. That's at day 7, day 30, and day 90. So the day 7 and day 30 responses were compared with corresponding day 0 concentrations. And this is just to serially, assess the responses of the same sample matrix. For the day 90 responses, these were compared with corresponding plasma samples. And for this set of samples, we didn't really assess the day 0 antibody levels. So they were collected at an offsite lab. But the plasma antibody responses from the other samples were quite comparable to day 0 responses of DBS. Anyway, so we did observe a trend of decreasing antibody levels, and this is for all the analytes on both the DBS filter and DBS Mitra on the right. There seems to be a consistent pattern of decline, a decline over time, and this is of the antibody levels. And if you check the specific estimates at different time points, DBS Mitra seem to show a much steeper decline, especially on day 7 and day 30. And then when it gets to day 90 time point, DBS filter seems to have a much steeper decline. You can see the shifts on varicella, rubella, and measles. However, the decline on day 7 and day 30 did not really affect the serostatus classification. And therefore, to do a serial analysis of the individual observations at day 90, and this is the time point at which the decline seems to be more significant. So the top panel represents the filter samples, and the lower panel is for Mitra samples at day 90. You can also see the trend of declining antibody levels on both filter and Mitra, and this is compared with corresponding plasma responses. The decline is significant across all the analytes. These are just representative, analytes, but the observation was replicated across all the 7 analytes. So then with this significant decline of antibody levels, especially at day 90 after room temperature storage, what is important to know is, does this decline really, affect the serostatus classification? And conducting pairwise comparison of serostatus classification both for filter, this is on the left, and the Mitra samples on the right, It shows there's no significant misclassification for quite a number of analytes. For example, diphtheria on both matrices, pertussis as well, measles, rubella on filter, and varicella on Mitra. However, tetanus and mumps seem to be, stable in terms of serostatus, even after 90 days. I think I'll stop here and hand over to Makobu to wrap up the presentation and summarize. Over to you, Makobu.
All right. Thanks, Rose. I may have clicked something on the. I don't know if the presentation is visible.
It's not currently visible. Let's see if we can get it back.
Yeah, great. Yeah, it'll come back. Yeah.
There we go.
All right. Thanks. So I'll just try and wrap up what Rose and I have spoken about. Disclaimer, it's bath time at my house. It's going to be a little noisy. Ignore that noise. The first thing is that that Rose has walked you through is that the antibodies on the plasma were actually comparable to both the DBS filter and the Mitra at the baseline for the 7 VPDs. So what this means is that it actually worked exactly as we wanted it to do. When now we talk about the different storage conditions. So for the dried blood spots, at 90 days, there was a little bit of a reduction in the antibody levels. But, for the filter paper, it didn't seem to affect serostatus. You'd still get a result that would be comparable to the venous blood. There were reduced antibody levels for the room temperature storage at both day 7 and day 30. But again, this, similar to the point above, did not seem to affect the overall result. So it may be just a quantitative reduction, but doesn't affect the serostatus. However, at 90 days in room storage, there was a significant decline in the antibodies, which means that there was a bit of deterioration, specifically for tetanus and mumps. Rather than specifically, interestingly, mumps and tetanus do maintain their serostatus even after 90 days in room temperature. So to tie that together is that it seems that the DBS, both the dried blood spots from the filter paper or the Mitra devices, were relatively stable and comparable to venous blood, with a few caveats I have issued above. From the fieldwork, we suspect that the knowing what familiarity with what may have affected. There could have been something called pick and bias. So the users were more inclined to be more comfortable with what they're already used to, despite what we thought when we set out, hoping that the dried blood spots would be thought to be much easier to do. Interestingly, and I said that I was giving my results, is that the healthcare providers prioritize participants' comfort over their own comfort and ease of use when they were speaking of which device they thought to use. We we accept a limitation, and that is when we set out to do this study, it was more user-centric, and so a lot of the data we give are more from the user's point of view, or the operator's point of view, as opposed to being from the users, the healthcare, the participants' point of view. So perhaps to mitigate this, maybe a study that's a bit more patient-centric would be interesting to do. And then finally, I did show a picture of how the device looks, but the Mitra device comes in, it's in a plastic, it has plastic covering, then you open a foil paper, and then the clamshell is also covered in a secondary plastic film. And so that, to us is it's quite a bit of e-waste, and so, or rather, it generates a lot of plastic and aluminium foil waste that you don't use. Actually, all you need is a clamshell. So that may be a setback. And related to that, and again, this is specific to our setting, it was very expensive to get the Mitra devices. We imported them from South Africa, and when we look, including cost of shipping and customs and everything that we had to pay, was about $13 a piece, which in real sense may not be scalable. And so that's one of the things to look into that would need consideration if this was to be scaled up. So I'll stop there at this point, just to acknowledge a really big team of people that were behind all of this. So Eunice Kagusha, who is sitting in this webinar, is the overall PI for the chemists collaboration. And then James Jagwange led the lab team, and his lab teams are also listed below. For the Nairobi Urban HDSS that's run from the African Population Health and Research Center. So we thank Abdallah Ziraba, who's the lead there, and from the Manyata site, whose results we don't display but will be available in future. We thank Godfrey Bigogo and Patrick Manyoki from KEMRI and CDC respectively. So thank you very much, and back to you, Neil, for any questions.
Thank you, Makobu, and thank you, Rose. That was a really, really interesting presentation and beautifully done and really well timed. We've got lots and lots of time for questions now, which is really good. And I'm just looking in the chat. I see there's a bunch of questions coming in. Just a reminder to everyone, please submit your questions through the chat function if you have them. But I'll go to the first one from Anaksha. Hi, Anaksha. Were the DBS and Mitra stored in airtight bags with desiccant?
Yes, the DBS samples were, are stored in separate Ziploc bags with around 2 sachets of desiccants.
Okay, thank you. Question from Erastus. These findings are really interesting. Which buffer was used to elute plasma from DBS?
Come up, the buffer?
Yes, for the elution.
Yes, so we do have an assay buffer. So we decided to directly, elute the samples using the assay buffer so that you don't get to dilute again. And that is PBS, twin 20 and 3% BSA. That's bovine serum albumin.
Thank you, Rose. So we have another question from an actor. It's actually 2 questions, so I'll split it up. Were all the samples collected by a trained person at the clinic?
Yeah, I could take that. So yes, so what we did prior to sample collection, we provided standardized training. So it was done by the same team at all 3 sites. So presumably everyone will have done exactly the same thing once they have received the training. So I suppose the short answer is yes, and the long one is just to explain how we did that. And I did supervise training at all 3 sites as I was leading this piece of work. So like I said in the presentation, what healthcare providers were asked to do is practice on themselves until they became comfortable. The team that we were using to train them was actually grading them. They had their own way of grading and seeing, how well was someone able to fill the spots on the dry bloods, on the filter paper, how well were they able to fill the tips on the Mitra, until and we did real practice with actual filter papers and Mitra devices. And so until someone had satisfied the trainer, were they then told you can then now go and do this. So yes, we did provide standardized training across the 3 sites.
But there was no cases where the patients were sampling themselves. It was always by a healthcare professional.
Yes, yeah.
Okay. And there was another question from Anaksha about the questionnaire. who was filling in the questionnaire? Was it filled in by the participant or by the healthcare professional? I think you said it was the healthcare professional, yeah?
Yes. So what we did, we trained pairs of healthcare providers who could do the exact same things. So at any one time, one of them would be collecting the sample and the other would be checking boxes, just because we knew it's impossible for one person to collect a sample and tick boxes in real time. So the same pairs did it each time. Yeah.
Thank you. There's a question from Wangesi saying, based on the operator experience, could you speculate on whether it might be feasible to have participants collect their own samples with parents collecting children's samples in the future?
So yeah, I had made a mental note to actually speak about at the Kilifi site. If in your mind you can remember the slide on the characteristics, there were no children under 5. So I think no mothers were comfortable having their child pricked, on the finger, So that was, I had made a mental note to bring that to your attention. Anyway, to answer Wangeshi's question, it's very likely that if we trained the community on how, and give them a rationale why they should collect the sample, there would be a bit of waste, but I think there would be more acceptability. I think a drop of blood, at least in my opinion, culturally, I think collecting a drop of blood and putting it on a paper would be a bit more appealing than the vacutainer, which people do feel is a lot of blood, even though it's about 5 ml. So I think there is, in my closing remarks, I said a larger, more patient-centric study would be important. That would be a really important thing to try and do. Give people enough training, let them test as much as possible. But yes, I think we'd have more children participating if the parents were the ones operating this.
That's really interesting. These are the details we're all eager to learn about as we roll out these technologies for different age groups in different parts of the world. We need to learn what works in different parts of the world. So this is just really, really interesting to me. We had a question about some of the sex differences, more males in Nairobi. Is there any particular reason for that? It was more even at the other side.
Yeah. So I think it's more to do with the populations. So at the Kilifi site, it's a rural setting. It's people in their villages doing, so the distribution would be what you'd expect in a rural setting. At the Nairobi Urban HDSS, it's more in a low social-economic status setting. I'm using polite language. It's really a slum. So a lot of the people there are only there to look for work within the industries around there. And so presumably a lot of them would be male. That's just how sometimes society is structured. Men will be the ones who sometimes go out looking for work, and so we'll be the ones in the slums. So that's one possibility. The other one is, not to say that there are lots of women, all these men have partners, but the other reason is men are more, in my experience, in a lot of other work I have done, men tend to jump into things a bit more quickly, research things. So whatever it is, I have done work on pre-exposure prophylaxis or vaccine trials. Women are a little more cautious when it comes to things that may affect their health. And so I think it's the same thing. There may have been more refusals from women. But again, all this is my thinking around it. We could delve deeper into the data and find that actually the male centricness of it may have been more children, so that may, those are my thoughts, but there may be other reasons around it.
Thank you, Makobu. We got another question from Bernadette. Why do you think some analytes were more affected in terms of sera status after 90 days room temperature storage? So I guess that's more for Rose.
Come up again, please.
Why do you think some analytes were more affected in terms of serostatus after 90 days room temperature storage?
Yeah, so I mean, and many other studies have also, found similar findings, whereby the antibodies, tend to reduce when stored at room temperature, and this could be due to protein denaturation, due to the temperature and humidity effects, and this may tend to probably alter conformation of the antibodies, probably rendering them inactive. But I think, yeah, that could be, a potential explanation.
And building on that, is there an explanation, Rose, on maybe the difference between the dry blood spot samples and the Mitra VAMS data for the stability?
Yes, yes. Especially, our observation on the frozen DBS filter samples. There seems to be, a decline in the levels, and also again potential explanations to this could be matrix interference, because the DBS filter paper has can have matrix effects where the proteins and probably other components of blood can interact with the paper fibers. Then over time, these interactions lead to degradation of the analytes during the storage. Again, even considering the more porous nature of the filter paper, because this was not really observed on the Mitra, and because the Mitra, microsamplers kind of collect, modified volume, minimizes the matrix effects, where with the larger and more variable volumes, absorbed by the filter paper. So yeah, maybe the Mitra had minimized exposure to degrading factors. Yes, that I think was a very interesting observation.
Yeah, and just an observation from my own experience, Rose. We know that sometimes the drying effects keep on going for a long period, for days, weeks, and months. And sometimes what looks like an instability is actually not instability, it's a recovery problem. And because the blood is still changing with time. So it's not sometimes that the drug is unstable, it's that you're not necessarily getting good recovery. Do you have any measure of the recovery of these analytes? Is it generally quite high recovery?
Yes, yes, yeah, they're comparable with plasma responses. I mean, that's at baseline, but now for these, freeze stored samples of the room temperature stored samples, kind of just tends to reduce.
Yeah, no, it's interesting trying to figure out whether something's instability or whether something's an aging problem with blood, because it's really weird the way the blood just keeps on changing over time, and therefore recovery changes with time. Another question from Anaksha here, and I think this is for you, Makobu. Thanks for sharing your results. Your participant survey data are very interesting data. I'm curious as to why most of the participants thought venipuncture was less painful.
Yes, so that wasn't actually the participants, it was the healthcare providers who, I suppose, when they observe, and this was subjective, apologies for that. It was very subjective once they observed the participant, probably who are so used to having venous blood drawn, and so would maybe stretch their hand, get the tourniquet done, and get this over and done with. However, when trying to do the fingerprint, which is a new experience for both of them, the tag team, the other healthcare provider would be watching. Is this person squirming? Are they, anticipating pain? Are they acting like they're in pain? And so once that data was then inputted, that's when someone says the venous blood seemed to be less painful. Now, yeah, so to tie that up, it is from the healthcare provider's point of view and not from the user themselves.
Thank you, Makobu. One thing I'm also interested about is key learnings about the training. If you did this again in another study, would you do the training in a different way?
If we were to do it again, I think the main thing would be, even in our conception of the whole study, would be more patient-centric. And so we would have questions, or at least we would think about how do we integrate the end users' points of view into this. And so the training, I would probably do it the same, but I would probably have a component, maybe a comparative arm where, which I like the question that was asked, where we would have healthcare providers collecting one bit of them, and another arm where there was self-collection, and then see, do these results look any different? Yeah.
Yeah. And you know, I think a lot of the experiences, once the second sample, people find easier when they've got past the familiarity with something that's a little bit strange to them with the finger prick. The second sample they find easier to do. It's often higher quality and maybe less concern about it. So are there any of your studies where they take more than one sample over time at all that might be interesting to look at as well?
So the parent study that this was nested in did multiple rounds of serosurveillance. It's now the funding that was supporting that has since run out. But if there was opportunity for that, we would exactly do another round where people now would be reminded. Last year, during sample collection, we introduced to this device. Are you still interested in it? A lot of the participants are it's a random sample, so we may not find the exact same people, but there would be overlap at some point. So yeah, it would be something worth thinking of. Yeah.
And I think we've got the last question. Please describe the chemist collaboration a little bit more. If you'd like to share a little bit more about that, please.
Yeah, sure. So the Kenya multi-site integrated serosurveillance study was really a response to the COVID-19 pandemic. So in end of 2020, early 2021, in response to a call from the Bill and Melinda Gates Foundation, the people who are acknowledged in the final slide brought up a protocol where they would do serosurveillance for COVID-19 at the time when the pandemic was really at its prime, just to describe the spread, so that was what it was initially set out to do. As the pandemic began to level off, then other ideas were brought in. You already have the sample, you already have the population. So that's how we then began to look into serosurveillance on vaccine-preventable diseases. There's thinking around, working around even arboviruses. So it's the scope enlarged, but really the birth of this was was in response to serosurveillance for COVID-19. So that's the sort of platform around it, hence why the funding is probably running out.
Okay, thank you, Makubu. It's really interesting, and I hope you get some more funding because this is really important and really interesting work. So fingers crossed that you get some further funding to keep this moving forward. So with that, I think that's all of our questions for today. So Makobu, Rose, I'd very much like to thank you for your presentations today. Super interesting. I'd like to thank the attendees for their attendance and for their questions. As I said, this event has been recorded and will be available on the PCSIG website in the next few days for people to view. I just want to share a quick couple of slides about the patient-centric sampling before everyone disappears. So the patient-centric sampling is a group. It's a not-for-profit group that basically we're looking to enable patients to take control of sampling. We're a not-for-profit organization bringing together people from around the world. If you want to learn more about us, please use these codes to either take a look at our website or join our LinkedIn group, or please contact us at contact@pcsig.org. We've got lots of exciting activities. If you're passionate about patient-centric sampling and how we can bring it forward to more benefits, to more people, then please join us and help us with our mission to enable patients to take control of sampling. My next slide is just thanking all of our partners and sponsors. Thank you to the Evidence Base for enabling us to have these webinars, and thank you to all our sponsors that provide the funding that provides all these webinars for free and enables the support of our other activities. We don't have a webinar in August. We take a break for the summer holidays, but we'll be back in September. So please keep an eye on the LinkedIn channel and on the website for our next webinar in September. And with that, I'd just like to thank Rose and Makobu again, and thank all of you, and see you all in September. Thank you. Bye.